Hello, everyone. Before you listen to the podcast and hear our disclaimer, which we normally show you, I wanted to take this opportunity to apologize for the sound quality in the podcast you're about to hear. Like everyone else, we're using different video conferencing platforms, and what we have learned is which one not to use to record a podcast episode on. Never used it before for a podcast episode, so we had no experience with it. I want to apologize to my guests from Brigham Women and Children's Hospital who were outstanding and did a wonderful job, and we had a great conversation. And to you who are going to listen to it, with the pandemic bearing down on us, we did not have the time to re-record this episode, which would have been the most ideal setting, but we wanted to get the information out. My guests actually are attending and taking care of patients this week because of the increase in patients from COVID-19, and they took the time out to record this, so I did want to also apologize to them. My hope is that you can find this episode helpful in some way, shape, or form. We had great conversations about the airway management of adults with COVID-19 with a focus on pediatricians who may be taking care of these patients. And in addition, we reviewed asthma, the differences between that in adults and pediatrics, and reviewed COPD. So I found it to be a very helpful conversation, but I do apologize for the sound quality of the audio of this podcast. I can tell you things we learned is which meeting hosting platform we will not be using ever again for podcast recording. If that helps, I don't know. If it does not, feel free to email me with any complaints. You all have my email address at this point, and it's always at the end of the podcast episode. Again, I apologize. Thank you all very much for your time.
This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients.
Welcome everybody to another episode of PHM from Pittsburgh. I am your host still, Dr. Tony Tarchichi. I'm a med-peds trained pediatric hospitalist at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We've been coming to you since October of 2016, and as I don't have to tell anybody, COVID-19 has really taken over just about everything everybody does now in the hospital. They're either preparing or dealing with an influx of patients for COVID-19. So what we have been doing is coming to you with these crash course episodes in partnership with the Popcorn Network. And for those of you who don't know yet, the Popcorn Network stands for the Pediatric Overflow Planning Contingency Response Network. It's a multi-institutional collaboration to help support the safe offloading of adult patients to pediatric facilities. Their mission is to provide pediatric providers and health systems to have access to the tools in the community necessary to care for adult patients during the COVID-19 pandemic. They approached us to collaborate a few of these episodes, these crash course episodes. We were obviously happy to help in any way we could. This is our second crash course episode. We're going to focus on the lungs here. For everybody out there, I hope you're staying safe, so let's dive right in. I want to introduce our expert guests who've taken some time out to talk with us today, which we really appreciate. I'd like to introduce, we have two guests today. The first guest is Dr. Ahmet Uluer. He's a med-peds trained pulmonologist and currently the director of the Adult Cystic Fibrosis Program at the combined Brigham and Women's Hospital and Boston Children's Hospital Cystic Fibrosis Center, as well as a director of the Weitzman Family Bridges Adult Transition Program. That's a program that consists of four things: an inpatient service run by FNPs for adults with chronic diseases of pediatric origin, a consult service that provides age-appropriate medical oversight and transitional care support for adult patients not admitted to their service, a consult service for sexual health and fertility, and an ambulatory clinic and consult service for transitional care support to all programs throughout Boston Children's Hospital. He sees patients in general pulmonary clinic, but focuses on adults with CF, non-CF bronchiectasis, asthma, restrictive lung disease, and trach vent-dependent patients with consisting of congenital diseases. So that's one of our guests. I'll thank them both together. And our next guest is Dr. John Kennedy. Dr. Kennedy trained in internal medicine and pediatrics at the University of Rochester and in pulmonary and critical care medicine at Brigham's Hospital. Dr. Kennedy is an instructor of medicine at the Harvard Medical School and attends on the pulmonary transplant service, as well as the Brigham and Women's Boston Children's Hospital Combined Cystic Fibrosis Service and the Weitzman Family Bridges Adult Transition Program team, which we just read about. And he's also an assistant professor of medicine at the State University of New York in Stony Brook. So Drs. Kennedy and Uluer, thank you very much for joining us.
Thank you, Tony. Happy to be here.
All right, so let's do our disclosure statements. I will go first, and then John will kick it out to you, and then Ahmet, you're third. I have nothing to disclose.
I have nothing to disclose. I do have a adult care grant from the Cystic Fibrosis Foundation and a loan repayment grant from the NIH, but that's all.
And this is Ahmet Uluer. I have a disclosure and consulting agreement with Vertex Pharmaceuticals and ELOC as we work on clinical trials of their drugs for cystic fibrosis, but otherwise no other relevant disclosures.
Great. Well, let's dive right in. Well, we are here to talk basically two pediatricians who are now taking care of adults because of the COVID-19 pandemic. That's the focus and goal of this podcast. For those of you listening, we're going to try to give you as much information as we can. The first question I'll start with is one that I've been wanting to know about, so I'm so happy I have two experts on to ask them, which is people who have the virus anecdotally on TV, when you read about them, keep saying something to the effect of they feel like their lungs are filling up with fluid. So my question is that ARDS or something else? So I'd love to know if you guys can help me with that.
So this is John. So I've taken care of a fair number of folks now with COVID-19. Definitely, we're seeing some classic imaging findings on these folks. On a chest X-ray, we're seeing bilateral sort of fluffy appearing infiltrates to us. And then when we do a CT scan, we're seeing bilateral infiltrates and dense opacities too. In my experience, the folks that I've taken care of, and there are several dozen of them, have talked about sort of a burning sensation in their lungs.
Oh.
We're very familiar with taking care of folks with pulmonary edema, sort of flash pulmonary edema when their blood pressures get very high. These folks will come in with a real wet cough sometimes, and sometimes productive of frothy sputum. Our COVID patients are having a very, very dry cough and then this sort of burning sensation. Depending on their oxygenation and their readings on an ABG, this can be ARDS. Part of the criteria for diagnosing it includes new bilateral infiltrates, so they certainly fit that. And then we measure their PaO2 to FiO2 ratio to try to see if they're really having oxygenation issues. It's certainly possible that some of these folks are getting some degree of pulmonary edema, and I actually have seen that. But it wouldn't be the overwhelming lung phenotype that I'm seeing, cases complaining of burning and a drier lungs once they wind up on the ventilator, ones that are a bit more compliant and drier. So, yeah, I maybe there's some folks that feels like their lungs are filling up. Definitely, when your lungs fill up with fluid, you have a sensation that you can't catch your breath. And definitely these folks are tachypnic, definitely feel dyspnea. This is overwhelmingly, they're telling me they can't catch their breath, they can't catch their breath. So dyspnea is a big part of the symptoms that they're presenting to the ED with. But I wouldn't say, in my experience, several dozen patients so far, that overt pulmonary edema is the biggest or the very common presenting symptom. I don't know if that answers your question, but that's a little bit of what I've seen so far.
It does. That was great. Thank you.
I know I was going to say, John, you mentioned something in there and potentially something that's unique to people with COVID-associated respiratory failure. but the compliance, I don't know if you feel that is sort of unique to the ARDS you're seeing or the management of respiratory failure you're seeing with COVID, and obviously something that we've talked about. I just wanted to see if you could expand on that.
Sure, yeah. So, right. Typically with garden variety ARDS, you can't see the air quotes that I'm doing now for garden variety, but the lungs are stamped on the ventilator. And the ARDS that we're seeing now is really interesting. The patients are requiring high PEEP on the ventilators, high end expiratory pressures, which we have a protocol for how to manage them on a ventilator through the ARDS network, which includes starting at high PEEP and trying to get your oxygen level down as soon as possible, and giving low tidal volume and trying to measure low plateau pressures on the ventilator. So we're seeing a bit of that, but we're noticing that the lungs don't appear as stiff on the ventilator as they do with folks with garden variety ARDS. And in fact, there's a paper that came out, I believe, end of last week from an Italian group, and I'll reference that if needed for folks, where we're talking about two phenotypes of lung disease that we're seeing in these folks. And one would be sort of classic stiff ARDS, and another would be profound hypoxemia, but the lungs are much more compliant. And there are a couple theories of why that is. I'm certainly not the expert on that.
No, I was just going to add that, you've had other experts on here to talk about COVID, and I just wanted to, just have John expand on that. But it is, thought to be that there's potential some vascular injury that may be leading to that sort of observation and that management on the ventilator, and have maybe some implications on how we approach patients before they get really sick, and possibly before the patient gets transported to the ICU. But obviously, all of this is we're learning as we go. It is amazing how much we're learning every day. These articles are coming out on a regular basis. It's hard to keep up with the literature as we're also doing the daily work. And then we look back at SARS-CoV back in 2003 and MERS, and that's sort of extrapolating all that we've learned from there as well. But it is, these little details, I think, are hopefully going to give us insight into how to better manage, COVID patients going forward.
I think you're right. And I think one of the things before the patients, ideally before they get to you all, if they're taken care of by pediatric hospitals because the hospital is so overwhelmed, since John, you talked so well about the symptoms and the increase in PEEP, can we talk about, if I'm a pediatric hospitalist and I'm taking care of an adult, what should I see before I think about transitioning them up to high flow nasal cannula or CPAP or BiPAP? How should I make that decision?
Yeah, sure. So happy to do that. Yeah. Ahmet, if you'd like to talk about that, no problem.
I don't know if you were referring to this, Tony, because one of the, I think, issues that a pediatrician might have is how is hypoxemia maybe different than what they've seen in a child, where we may see more, accessory muscle use, and certainly different than in an infant than we're talking about kids and adolescents. But I guess one thing that I wanted to point out, and John can also speak to this, is that mild hypoxemia, may look like someone just having tachypnea or just breathing fast. And, early on, you may feel like someone is doing okay because you may not see such profound effects of hypoxemia, but you may see somebody who just maybe is slightly more confused. You would want to make sure that we're watching their kidney function and, their cardiovascular health. But essentially, the tachypnea might be the only thing you see. And John can speak to this more, but when we get to dyspnea, it is usually when people are pretty far along and, really looking at needing assistance in the ICU. Because that is usually when patients' hypoxemia is sort of beyond, sort of our cutoffs, which is, a PaO2 of 60 is sort of our magic number, 60 millimeters of mercury, but and with mild hypoxemia being between 50 and 60, to then below 50 really being when patients really start feeling, dyspneic. And so I think that just making sure that the pediatrician recognizes those early signs and making sure that we are giving the appropriate FiO2 either through nasal cannula, through masks, through, either a simple mask or a Venturi mask, or, going to, and I'll let John talk a little bit more about the, high flow nasal cannula and, and non-invasive ventilation and, how we can deliver that safely in COVID. But essentially, I just wanted to point out that the early signs of hypoxemia can be a little bit different than what we might be expecting, in children.
Can I make sure I understand that before we go to my question? Because I want to make sure I get that right. So if a patient I'm seeing, an adult patient, is tachypnic, and alone tachypnic, I'm going to go look at them. I'm going to get a pulse ox, and if it's lower, which I assume is under 90, is what I would say is lower, I'm going to guess that their PaO2 should be around 60 or above 60, but that brings up a point of, in pediatrics, we're used to and primarily use VBG, or venous blood gas. If we have an infant or a child who's tachypnic or having some distress. But in adult medicine, I remember from my training, we really did ABGs, or arterial blood gases. Am I right there?
Right. Yeah, that's right. I think that I'll just finish my thought and then I'll let John take over. But I think that, the pulse oximeter is a good way of just making sure we're screening patients. And, some may argue that, having someone be 90, especially in the acute setting, 90 to 92% might be where they're more profoundly hypoxemic than you might think. So in that case, especially with adult patients, we often are more aggressive in getting an ABG to at least verify the PaO2. We may be below 60, even at an O2 set of 92 and 93%.
John, did you want to add anything to that?
Do you want to expand on that? Yeah. No, that's a great point on it. Anyone that I'm looking at closely have a very low threshold to obtain a blood gas, so I can decide how to triage them, whether I can continue to manage them on the floor, whether I need to bring them into the ICU or consult a colleague who can help with that. So I think those are great points. And I think the question of how to best supplement oxygenation in these folks is something that each system is struggling with on their own. I think nationwide, some guidelines have come together that most folks are using. So at Brigham and Women's, our guidelines are that we'll give supplemental oxygen up to about 5 liters, and then we'll switch to 5 liters nasal cannula, and then we'll switch to a Venturi mask. But we don't give humidification with the Venturi mask, and that's so we don't aerosolize droplets of the virus. So we'll do a what we call a dry Venturi mask up to about 50% FiO2, and then the protocols for us and for many others around the country, depending on other factors as well, not just oxygenation. But if the person continues to struggle, then most folks are moving to early intubation as opposed to something like high flow, nasal cannula high flow, which we use in a pure oxygenation issue, or something like bypass, which we use more with a ventilation, oxygenation and ventilation issue, i.e. like the pulmonary edema we were talking about earlier. These are institutional decisions and decisions that are debated among critical care docs as well. And these are mostly to maintain a closed circuit in someone who potentially has the virus. More and more of us are, as we have more patients on ventilators and the resources become stretched, and also as we're realizing that folks are staying on ventilators for 21 days and more, which brings up other questions of tracheostomy and how safe is that. Pushing to use hypo potentially early as a bridge, but most of us want to do that in the negative pressure room, if able, just to protect staff and to protect other patients. And this is debated, and this is something that institutions are coming together and putting guidelines out for. So our practice currently at Brigham, because we still have resources there speaks a little to early intubation. In my experience, more recently in New York, where we're stretching our ventilators, folks are looking to move to high flow in a negative pressure room in specific patients as a way both to bridge potentially to recovery and to avoid aerosolizing procedure in a room that's outside of negative pressure. I think it's a caveat, and it's a nuanced question, but that's sort of the world we're living in now. We're sort of working with these moving issues.
And Tony, I was going to just add to that just a couple more things. There's another option, obviously, for high flow nasal cannula and from the venturi mask, and that's the non-rebreather. So you have some additional option to increase your FiO2, which venturi mask is, about, I think, max 50%. I mean, that's a great point about not using humidification. But then with non-rebreather, you can increase that. And another thing, and it is really in the COVID era that we're not able to, trial some of these very, traditionally things that we use first, the high frequency, the high flow nasal cannula and the non-invasive, positive pressure ventilation, because of this aerosolization issue. But I do feel like that could help in some cases prevent people from being intubated. So there is concern that this just delays it and increases risk. But one thing I would add is, if you are in a situation where ventilators are scarce, another type of mode of ventilation, or in positioning specifically that they do in the ICU is prone ventilation. But you may want to trial prone ventilation also pre-ICU. The reason that this is a concern is because the worry that positioning a patient with lots of support from nursing and physical therapy potentially, once again, increases the risk of aerosolization and a risk to the provider. But if we can do that safely, negative pressure room, proper PPE, that might save a patient from maybe needing a ventilator or being intubated with prone positioning and using high flow nasal cannula. But, we are, and as John said, this is, the new reality we're in. But for the pediatrician at the bedside, that might be another option as you're trying to mitigate, the respiratory distress and failure that the patient is experiencing.
Ahmet, I 100% agree with you, and I have used it at least 3 times now to try to stave off intubation, and it's worked each time. The patients that I've chosen to ask to self-prone have been patients that were awake enough to do it on their own. The concern for me with asking a patient to self-prone is, am I delaying intubation in someone who's borderline? We've seen the hypoxemic respiratory failure progress so rapidly in these patients in the order of 4 to 8 hours, going from speaking in full sentences to needing to be intubated. Wow. So when I approach a patient on the floor who's in some respiratory distress, who's on a venti mask, if they're awake and alert enough to understand me, and then I've asked them to get on their belly, and I watch them do it, and you can see the peripheral stats, anecdotally in my experience, jumping up 10%, 10 to 12% immediately. It seems to work. Again, you need to have a close eye on these folks because you want to watch it continue to work. If it's going to work, it's going to work within the first 5, 10 minutes, 10, 15 minutes. And if that doesn't work, it's okay to ask them to flip back. But I have seen in 3 occasions now where this has at least staved off intubation for some amount of time. And we believe the same physiology is in effect as when we're proning these people when they're intubated. People have asked us what's the amount of time that we should have a person prone when they're not intubated. The trials that we use to prone intubated patients tell us to do 16 hours on their belly and 8 on their back. Folks around the country have pushed that to even longer on their belly. So I've told folks, the amount of time that they can tolerate on their belly is how long we should leave them on their belly, but frequent checks so that we make sure we're not delaying intubation when we should be. But myself and my colleagues around the country are noticing that this is working. So definitely an important tool for the pediatrician the pediatrician who's managing these folks as well.
There's so much good information you guys just gave. I love it. Let me follow up with a question. Go ahead.
No, I was just going to sort of riff off that just one more time.
Sure.
And we'll let you ask the question, though. Is that, so when someone is supine, and another situation the pediatricians don't deal with, and it just came to me as on a regular basis, is the patient who might be obese. Because you're throwing in patients who may have not, been exposed to the medical system, and certain things may not be known to themselves. And the medical system, and they might be experiencing, especially with infection, inflammation, some obstructive sleep apnea type symptoms. So, in those cases, like the supine position would be not as good a position, and now we can't introduce non-invasive ventilation. So, putting them in the lateral recumbent or prone position, from your observation that they might be obese, may also be helpful from that standpoint in relieving some of that, some of the hypoxemia that they're experiencing. But just sort of trying to think about the pediatrician sort of vantage point here and what they may have experience with and what they may not.
That was going to be one of my questions, Ahmet. The obese young male or female patient that comes in and they don't know that they have sleep apnea because haven't been to a doctor. They're in their early 30s, let's say. And so I appreciate you bringing that up. I do want to ask one other follow-up question. So for those of us who we're going to be taking care of these kids or these adults, I keep saying kids. So John, you said they can go from talking in full sentences to need to be intubated in 4 to 8 hours. The respiratory depression happens very quickly. Did I hear that right?
Yeah, yes, we're definitely seeing a rapid decline in respiratory function.
Oh, wow. Okay.
So what I would say, and we are noticing, that there's some people who are having mild symptoms, no symptoms, some with some degree of illness, and some with severe illness. And a friend of actually both John and I, and I'm going to give credit to Dr. Ruby Wang on this one, but the term too little too late, actually the term too much too late is sometimes what ends up happening, and that is where John takes over and our critical care colleagues take over, is when these patients have too much immune response, that sort of the cytokine storm that's being described at a time when maybe it's too late. The viral process has sort of been initiated before, and maybe that's sort of going away, but then you have a patient who may be lymphopenic and then dealing with this overwhelming inflammatory response that caused problems both in the respiratory system, but also we're seeing, myocarditis, other potential complications. But it's that, and that's when John is called and is taking care of these patients, right during that very rapid deterioration, side of things. And we've seen some complications at the Brigham with the lymphopenia that also adds some interesting points to this. And probably this is not necessarily something that the pediatrician needs to think about, but I just thought was interesting. And John and I have talked about this, is the potential for other opportunistic infection, at this time, and, making sure that we are recognizing these changes and covering patients for, a bacterial complication, pneumonia, as well as their viral pneumonia. I mean, that's not always going to be necessary, but something that, we might want to consider is initiation of antibiotics potentially. But we did observe a patient with PCP recently, which was really surprising to us, but in a patient whose risk factor was lymphopenia and not necessarily, something else, and potentially lymphopenia was there, longer than we knew about. That sort of late worsening that we're observing, may be from multiple reasons.
That brings up an interesting question, Ahmet. For pediatricians, when they have a patient with a virus and an infiltrate on X-ray, and I know from the Chinese literature, infiltrates on X-rays and CAT scans are very, very common in these patients with COVID-19. But a pediatric hospitalist will look at the infiltrate and know it's a virus and say this is a viral pneumonia. There's no reason to give an antibiotic. They may use the procalcitonin if they have it, if the patient wasn't pre-treated with antibiotics. That's kind of what they normally go to. But for these patients, you're saying, and I think others have said as well, that they are likely, because of the lymphopenia, which is strongly associated with COVID-19, to get secondary bacterial pneumonia. So they should be, if you see the infiltrates on x-ray and they're having signs of anything, tachypnea, hypoxemia, any of it, they really should be covering with antibiotics just in case. Fair to say?
Yeah, I mean, I think that there is some evidence in literature, especially with influenza, about use of antibiotics, and so what they're seeing is very likely a viral pneumonia. Antibiotics are not necessarily what should be called for. We don't necessarily start antibiotics in all of our patients. I think that it needs to be an individualized approach, but in patients that I take care of, much of the time, who have bronchiectasis may have a chronic infection sort of in the background. Some people call it colonization, some people call it a chronic infection. Then they might be at risk, and you do need to make sure you cover them for the bacteria that will definitely complicate that picture. And I think with the patient who's lymphopenic, I think that we do need to recognize that there may be a bacterial infection that complicates the picture. And so that initiation, that can be a shared decision with your infectious disease colleagues. But if you're there on your own, we do know that there's been some studies, I can't cite them right now, but I will get that reference for you guys, that show patients who were treated with antibiotics, and had influenza, and this is with COVID patients, that they often do better than those who do not get antibiotics. But this is, in a select group of patients. But we just need to make sure we recognize that, this is likely viral pneumonia, but that there can be potential bacterial complications. And, you have to look at the patient and their risk factors to see who might benefit from, an antibiotics, especially those who may have recovered and then are worsening. Though we're seeing that purely due to COVID, it may be also due to a bacterial infection. So I would tend to err on the side of starting antibiotics earlier.
Yeah, I think that's a good point, Ahmet, and I think that's kind of my practice as well. When we, 2 or 3 weeks ago, when we were all pouring through the data, we all reviewed a couple papers out of Wuhan that were showing that the rates of bacterial co-infection seem to be fairly low. There's a paper by Xiao in the Lancet 2020 and Young in JAMA 2020, which were showing rates of bacterial co-infection that seem to be 15 or 15% or so, 12-15% initially at initial presentation. So we were all thinking that we'd be holding back on antibiotics in these folks. But obviously, as folks become hemodynamically unstable and wind up in the ICU, I have to think about systemic bacterial infection. Again, the literature from Wuhan is saying that, in general, at least at presentation, the rate of co-infection should be, under 20%. But I absolutely agree with Ahmet that, especially if there's recovering and then worsening, or if someone is hemodynamically unstable and with me in the ICU, I'm frequently having some antibiotic on them as well. The other interesting point for co-infection that we should bring up is that there's this risk of respiratory viral co-infection that we were seeing in the first weeks of treating folks here. Initially, when tests were more scarce, we were doing our broad respiratory viral panel, or if there's anything on that respiratory viral panel, we wouldn't offer them a COVID test, again, because of scarcity. But then reports are coming out saying that up to 25% of folks can be co-infected with a different respiratory virus. I think rhinovirus is the one that we're most commonly seeing. There have also been reports of influenza. Influenza A was around late this year. If you had influenza A in someone, potentially we have something to help, although those medicines aren't great. But also to look for co-infection with another respiratory virus is something that I've been doing now as well.
Have you found anecdotally, John, that those adults are doing worse if they have more than one virus?
Yeah, well, not rhinovirus in general, but the small band of folks that I've taken care of with influenza A as well have done much worse. Yeah.
So I didn't plan on asking this next question, but the conversation's going in this direction. I'd love to know what your opinions are on the debate of steroids with COVID-19. I've read both sides. It seems to be an ongoing debate. But have you all read more? Have you been using it? Do you think it's helpful?
Yeah. So anyone? Sorry, Ahmet, do you want to start?
No, you go for it.
Okay. So again, right? There's two sides to the coin. The literature on influenza is showing us that if we treat with steroids, we're more likely to increase viral propagation. And some of us have leaned on that. The literature on cytokine storm, like Ahmet brought up, is showing us that maybe we should be inhibiting the immune system early. The folks here who are working on IL-6 receptor blockers are saying that their biggest benefit is when they get it early. And when that doesn't work in their cases, they're giving glucocorticoids, hydroglucocorticoids. Anyone who's been on chronic steroids, that's easy for me. Hypotension, chronic steroids, easy to pulse them with hydrocord. But I think, I don't know, in the ICU, in the sickest patients, we have a saying, which is not necessarily evidence-based, but no one should die without steroids. And in general, in my sickest folks, my folks with multi-system organ failure, we're trying it. I anecdotally can't say that I see a big benefit, and there's no other literature that is pointing me strongly in one direction or another. Again, it's very much a case-by-case basis for me, and I don't know if Ahmet's practice is any different.
Yeah, no, I think that I agree with that. This is something that we're going to struggle with as we look at the influenza literature as well, and we certainly don't want to do any harm by starting patients on systemic steroids too early or at all. We are, as I said before, learning so much every day, and maybe things that we were hesitant to start and then potentially missed the boat on, we are starting to think about earlier. And but I think in general, the sense is that starting systemic steroids may potentially make things worse.
Yeah.
So that's why we're so hesitant to make that decision. I think mostly we feel confident about people, like, for example, if someone has an asthma exacerbation and they're having asthma and, maybe they're co-infected with COVID, we still need to treat that airway inflammation and, bronchoconstriction, and we may need to do steroids. And so we're going to have to, treat the underlying disease that person might have no matter what. We want to make sure people who are on inhaled steroids continue them. And sometimes I'm concerned about mixed messages, and patients will start to remove their inhaled steroids because they're worried that steroids makes things worse with COVID. And so we need to be careful with that messaging, especially, a patient who's not even infected yet, or the pre-ICU patient, since we need to treat the underlying process. But there are definitely cases where we have started the steroids and the patient has gotten better, and we, congratulate ourselves thinking that, and potentially that was the reason why someone survived, and certainly the mechanics on the ventilator that may indicate that was the time point when someone improved. But then there's other cases where we see prolonged, viral expression, and worry that the steroid, was contributing to that. So it is very difficult, individualized approach, and certainly last-ditch effort to try to save someone's life, is the way we probably tend to look at it, but more concerned than not right now.
This conversation has been fantastic so far. I mean, we've really I've gotten a lot out of it. I've learned a ton. I do want to transition a little bit, since you brought up asthma, Ahmet, to, pediatric. So pediatric lung disorders that pediatricians are most comfortable with is very likely asthma, since you brought it up. So I'm going to ask you guys two questions at once, just in the interest of time. The first question is adult asthma any different than pediatric asthma? Do we treat it differently? Should we think about it differently? The second question is, I have looked through the literature and I found nothing about how asthma patients are either doing better or worse with COVID-19. I found absolutely nothing. So if you all have either read something that I've missed and or anecdotally have not had many asthma patients or have seen a ton, I'd love to hear about both of those things.
Okay, great. John, I'll start, but then I know you definitely have stuff to add to this. So first of all, asthma, the management of asthma is not too different from kids and adults. However, I would say that kids with asthma tend to be, more atopic or more allergic than their adult counterparts as far as their triggers. But that is not, of course, fully true. We have absolutely atopic adults, and those whose triggers are from allergies. Though virus infection still is one of the biggest triggers of exacerbations for most people. But one thing that I would say that in adults potentially contributes is like reflux. Think about maybe sinus infections, sinus disease, and post-nasal drip a little bit more. And then obesity and other things that might be contributing. But I would say that that's maybe, the differences in how you might recognize if someone's having asthma exacerbations or triggers, and potentially making sure that adults, their reflux is well controlled, that we're thinking about treating a sinus infection is kind of the approach I would take. But as far as management, I think that they're similar. Obviously the bronchodilators, like short-acting bronchodilators like SABAs, are the mainstay in treating patients acutely. There are certain adult patients who you need to be careful of, who may have cardiac arrhythmias, may have paroxysmal AFib that gets triggered, or SVT. And so you may choose to use, the other agents, the antimuscarinics or anticholinergics like ipratropium, and, improve vagal tone and take that approach with those patients. But, the use of inhaled steroids along with a long-acting bronchodilators like formoterol, in instance, is sometimes what we use PRN in certain patients as needed instead of albuterol. But inhaled corticosteroids along with the long-acting, we won't go through, because I think it'll take too long and it'll be a big discussion. But we won't go through the GINA guidelines or the other World Health Organization, other groups, and ATS of approach to asthma. But I would just say that managing with short-acting, long-acting inhaled corticosteroids and then systemic steroids is still the mainstay of managing patients with asthma. I mean, there's certainly other medications that we use. Certainly, we don't use drugs like theophylline, especially in the acute setting, because of the drug-drug toxicities and other toxicities associated with that. Sometimes we will add agents like montelukast to someone, even the acute stage, because that might, in some cases, may be helpful. But often that's still not an acute management drug. Magnesium is another drug that we might use, that we would use in adults, in young adults and children. But I think that the message is, maybe you just have to be a little bit more careful with the kinds of medications you're choosing, and worry about some of the comorbidities that a patient might have, with asthma. And another group that I was just thinking of is the patient with heart failure. You do need to make sure that you're managing patients with heart failure because albuterol can sometimes potentiate people who are on Lasix and causing more hypokalemia that might impact, cardiac function. And so things that you might need to think about at that standpoint as well.
That was great, Ahmet. Again, I reinforce a lot of what you said. You laid it out nicely, how we deal with asthma exacerbation in adults, and the very few caveats for adult asthma compared to pediatric asthma. I think I'm just going to emphasize that, as well as the short-acting beta agonist for rescue, we're going more towards inhaled corticosteroids for rescue as well in the newest guidelines. Anecdotally, for years, my patients have told me that they've taken a puff on their corticosteroid inhaler when they were in distress, and I always reinforced what we thought was true was that steroids work over a longer period of time than albuterol. But more and more, our patients have shown us that an ICS and corticosteroids early are helpful for rescue, and now the science has caught up to our patients. A little bit of a caveat in the COVID era. We frequently give people nebulized budesonide in the emergency department during an asthma exacerbation, and you should do whatever you need to do to save your patient. But we're pushing more towards MDIs now over nebulizers. Obviously, some folks can't do an MDI when they're in extremis, and then they absolutely need a nebulizer. But if you can get away with an inhaler and not a nebulizer, again, we're just trying to cut down on the aerosolizing procedures. As far as COVID patients with asthma, I honestly, don't think I've had the challenge yet of a severe asthma exacerbation and coronavirus pneumonia at the same time. This is, as Ahmet brought up before, one area when corticosteroids would be a no-brainer as well. I'm sure that challenge is coming. Other rescues that we think of would be Heliox, which can be given through a closed circuit, and the data is plus minus on that as well. But magnesium for sure, and then corticosteroids would be my go-tos.
So the patients you've been taking care of, John, they haven't been asthma patients who are coming in with COVID.
Sure. No, plenty of people have asthma in their history. It's very common. There's this new debate coming up about whether coronavirus is hitting more people who are underrepresented more, and we know that those folks in general have a higher incidence of being diagnosed with asthma. And I definitely have had people that I've had to intubate who had asthma in their history. When I look at their tracings on the ventilator, I don't see what looks like a lot of resistance in general. So that leads me not to think that they're in an asthma exacerbation. But I'm sure we'll get patients like that who have both problems at the same time. And then I would reach for corticosteroids and continuous beta agonists. Knowing that continuous beta agonists can cause a type D lactic acidosis, and magnesium and potentially Heliox.
I would just add a couple things. One, so this is, and I'm so glad you emphasized this, John, because I didn't, but the inhaled steroid use actually is part of, the same guidelines that exist for children.
Right.
So the early ICS with a long-acting that is new as of 2019 as a guideline for initiating even as needed. So using an inhaled steroid with a long-acting as needed is very new. And our the primary care folks may not be totally aware of that use. And then also definitely starting in the acute setting makes sense. And then my other point was going to be, people with respiratory illnesses, and, as you said in the beginning, I do, and John does too, we take care of people with cystic fibrosis. We certainly think that these people are at higher risk for having potential complications and worse outcomes. And certainly we do know of a patient with cystic fibrosis who passed away recently in Chicago, but we have not seen overall a great number of these patients. And I wonder, asthma patients maybe who have already been trained to avoid people who are sick and who are probably practicing social distancing and physical distancing more aggressively. And now their community is also participating. And so hopefully they're avoiding getting that infection that someone also could have introduced to them more so. Our worry is that is not going to last. And then we're going to start seeing these people who are vulnerable present to us sooner than later. But in the end, I think that there is a component of that they have been avoiding people who've been sick so many years, for so many decades, that they're just really good at it. Though that can't be the whole explanation. There's maybe more to that story. We'll tell you. We'll share that in a future day.
That's good.
Yeah.
Well, we are 55 minutes in, so I'm going to ask you for an impossible task. Could you summarize COPD in a few minutes with the caveat that the gold paper for COPD is 141 pages long? For pediatricians who are taking care of adults, they may or may not have COPD. Who knows, it may be diagnosed or not, because ideally they're putting the pediatricians with younger adults. But can you briefly review COPD for pediatricians?
Sure. Sure. COPD is obstructive lung disease, trouble with emptying. We typically think about it in people who've had some smoking history in the past, although it's not necessary. Some other exposures can lead to obstructive lung disease. Frequently, our findings on imaging are emphysema, predominant emphysema, but centralobular. If we can do pulmonary function tests, we find obstruction in these folks. We find reduction in ratios and reduction in FEV1. If we're seeing this in a younger person, if we're seeing this lower low complement, we're thinking about genetic issues as well, alpha-1 antitrypsin deficiency, but that's rare. In general, our treatments for COPD kind of overlap with our treatments for asthma. We frequently want to get people on an inhaled corticosteroid, a long-acting beta agonist, and a long-acting muscarinic as well. When we're seeing an exacerbation of COPD, and we're seeing people retaining CO2 and becoming dysptic, our guidelines have been debated back and forth, but most recently, and I agree with them, are calling for a short course of corticosteroids, again, back to steroids, up to prednisone 40 for about 5 days, is generally what I do, and then antibiotics on a case-by-case basis. If we have infiltrates, we're more likely to do it. Otherwise, many of us are doing short courses of azithromycin, less for a little bit for its antibiotic effect, but also for its immunomodulatory effect as well. That's a bit, and I'm sure Ahmet has some more to add.
It's hard to sort of summarize this in such quick time. So I think you did great. And maybe one thing for the pediatricians is to, when you're admitting somebody, often we're not thinking about nicotine replacement. And if the person is a long-time smoker and they're coming in with COPD exacerbation, just make sure that you are addressing that, because that can then complicate symptoms if they're having nicotine withdrawal. And that might be just something you may not think about. But otherwise, there is overlap in treatment. And, sometimes in
This was great. I mean, I have to tell you, I really enjoyed this. This was a lot of really good information, power packed in. We're pretty much exactly at an hour, which is kind of what I expected where we'd be. But is there anything I didn't ask you all that you think we should have discussed that we didn't discuss?
No, I think, this discussion went well, and I'm happy to support my colleagues around the country more if there's anything else we can add.
Yeah, no, I think that, John brought this up before, but like pulmonary edema from a cardiogenic source, and potentially when you have a cardiologist on, you can have them speak more to this. But that would have been the only other topic that I feel like a pediatrician may not recognize is taking care of somebody with heart failure, and especially someone with preserved systolic function, which is a more challenging diagnosis to make, and just making sure the evaluation does include heart failure. Sometimes that can mimic COPD, asthma exacerbations, and really, some of the treatment for that would obviously be different.
Yeah, I think that's a great point. I always think about the cardiac needs. I agree.
I think I'll talk to the Popcorn Network and see if we can get a cardiologist on and discuss heart failure in the setting of COVID and respiratory issues. I think that's a great point. I can't thank you two enough, John, Ahmet. This has been really helpful, really informative. I really appreciate you all taking the time out and joining us for this. Thank you so much.
No problem, Tony. Thank you for inviting us.
So for those of you at home, I hope this helped. I hope you found this helpful in some way. If you're out there taking care of adult patients through this whole COVID process, we will all get through this. We'll come out this on the other side. Thank you for all you're doing. Thank you for any healthcare workers out there taking care of these patients and working hard with them. We will continue to do this, and if there's anything we can do that is helpful to you all, please let us know. We'll put out whatever we need to. I'd love to get back to non-COVID topics on the podcast, but, that'll happen at some point. So thank you again.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.
Thank you for